to show the audience first?
I'm on.
Okay, everyone in the room knows who I am, but I'll go ahead and for my camera audience, I will introduce myself. My name is Brandy Merbarger, and I will be presenting today on patient safety culture and error reporting. I chose this topic of error reporting because the concern of underreporting, particularly in regards to medication errors, came up frequently in our quality meetings. The research proposal will discuss the importance of error reporting, the barriers to reporting, a literature review, the PICO question, nursing theory, and the proposed research. The Agency for Healthcare Research and Quality defines a high reliability organization as an organization that operates in complex, high hazard domains for extended periods without serious accident or catastrophic failure. The setting of interest for this proposal is a rural hospital in Southern Illinois. The current policy that is in place states that any unusual event involving patients or visitors should be reported. Those events include anything to do with bodily injury, property damage, medical equipment failure, error, delay in service or treatment, or significant risk thereof. The appropriate policy for error reporting is in place so that the concern for underreporting is based on culture rather than the actual policy that's in place. So when a culture of policy exists, there is an increased willingness to report because nurses can see that the results are non-punitive and their reporting actually results in change. So we define medical errors as an adverse effect of medical care. They're the cause of approximately 250 deaths each year in the United States, and approximately 86% of safety events are not reported. So the barriers to reporting include insufficient action by leadership, and oftentimes that's just a perception that staff see. Lack of knowledge, they may not know what to report, how to report, and then the fear of retribution, not only from leadership, but from their peers as well. Negative outcomes from not error reporting include workarounds being developed and the potential for future harm still being there. So I completed a literature review study, and the first study took place at Namazi Hospital in Iran. It consisted of 60 nurses and 20 supervisors in 6 adult ICUs. They utilized the hospital survey on patient safety culture. They did that before and after their intervention. The intervention consisted of an educational program on patient safety culture, which was a 2-day workshop, safety-themed posters and pamphlets, and the introduction of the Team STEPS program, which stands for Team Strategies and Tools to Enhance Performance and Patient Safety. Out of that study, after they retested or resurveyed, the statistically significant findings, errors that were impacted on the survey were domains of communication, handoff, teamwork, and continuous improvement. Clinically significant findings included non-punitive response to errors. That area greatly increased, and that indicates that staff are more willing to report errors when they think it's going to be non-punitive. The second study took place in Northwest Iran. It consisted of 256 emergency department nurses throughout 18 different hospitals. They did utilize 3 different survey tools, and they used those to examine the relationship between safety culture, leader behavior, and error reporting. So the 3 tools that they used, once again, were the hospital survey on patient safety culture, coaching behavior scale, and the intention to report errors questionnaire. Statistically significant findings in this study, they found that a higher perception of safety culture does increase the intent to report errors, and higher scores on the leader coaching behavior questionnaire increases the intent to report errors. So that just basically, you can take from that whenever nurse managers, hospital leadership are supportive of safety culture and providing an environment that's open to reporting, nurses are more likely to report those things that are occurring. The third study took place at a 145-bed PD hospital in the Midwest. They implemented their intervention hospital-wide. They chose to focus on the data of hospital-acquired condition rates, severe safety events reported, and the number of event reports entered. So they implemented a program that they called the No Harm Patient Safety Program. They implemented safety moments, leadership rounding, identification of priority hacks, the ION safety campaign, and safety coaches at the departmental level. Findings included a decrease in severe safety events, decreased CLABSI rates. They also saw decrease in CAUTI and SSI rates, and they also saw an increase in event reporting, specifically those near misses. The fourth study took place in an academic setting at Southeast Missouri State University. There were 141 baccalaureate level nurses. They designed two different programs. One was a student designed simulation program, and in that intervention, all of the nursing students were giving like a safety situation, and they had to prepare a response, how they would deal with that, coach their teammates, and then turn that into their instructors. And then they also had a good catch error reporting program where nurses were in the clinical setting. They were encouraged to report any near misses or safety events that they observed, and then they would report those to their instructor, and they would go over them, and if it wasn't a true safety event or wasn't truly a near miss, they would give feedback on that. So the purpose of doing that was to introduce a safety culture at the academic level, giving them that exposure so that when they go into practice, they have more knowledge and are able to report those things. So they did have statistically significant findings. Whenever they did the assessment tool, there was an increase of 37%. The last study that I looked at, they just did a review. They did conduct the hospital survey on patient safety, and they correlated some findings that nurses who had experience with previously entering any reports or had previously participated in some type of safety program, they had more safety awareness, and they did report errors more frequently. So the PICO question that I asked in order to get to all of this research is, on nursing units, what is the effect of an implemented safety program compared to having no safety program on error reporting? So the obvious population is hospital nursing units. Intervention was implementation of a safety program comparing to no safety program. And the outcome is a comparison of the number of errors or near misses that are reported before and after that intervention. Jean Watson is a nursing theorist, and she developed the philosophy of science and caring. Her theory consists of 10 curative factors. They serve as a framework for the way nurses provide care, not only for their patients, but for each other. You can flip to the next slide. So I have outlined there, those are the 10 factors that she developed. I'll talk about 3 of those that stuck out to me that really support this research. The first one was helping, trusting, and caring relationships, a teaching, learning environment, and a supportive and protective environment. So when all of those things exist, it does improve the safety culture, and nurses feel safe in reporting. The proposed research would be quantitative, quasi-experimental, and would take place in a 110-bed acute care hospital in rural Illinois. Intervention would consist of implementation of a safety program, which would include education and printed materials. That would go out to all inpatient nursing staff. Anytime you do a survey, Participation is voluntary, and that just participating in that survey does imply consent. Participation in education, there's no confidentiality or consent required. So the goal would be to establish what the baseline survey or baseline safety culture is, and then reevaluate that safety culture post-intervention in education. So that would be done using the hospital survey on patient safety culture. That was a survey that's designed by the Agency for Healthcare Research and Quality, with input from the Joint Commission, safety researchers, hospital administrators, and professional associations. So it is determined to be a reliable survey. It consists of 42 questions among 12 composites, and they assess this culture of patient safety within an organization. Data would also be collected on event reports. That's a little bit more difficult to measure just because it's dependent on human behavior. You can't really consistently measure it. But you would utilize that to determine how the implementation of a safety program impacts your error reporting. And I did attach a copy of the hospital survey on patient safety culture for your review. Data would be analyzed using a dependent groups t-test with a confidence interval of 95% and a level of significance less than 0.05. In conclusion, safety culture is an important factor in nurses' willingness to report actual and near-miss events. A robust safety program could improve the culture of safety, impacting errors being reported, improvements being made, and better patient outcomes. Culture safety equals patient safety. The end.